Have no financial interest. This is, in fact, I think when we look at what we're currently doing, where the improvement comes from is looking where the errors are. And you heard a lot of great talks this morning. You know, one of the things I always worry about is we determine the axis from the topography, the IOL master, the keratometry, but we depend on our least, least skilled person, the technician, to make sure the head wasn't tilted. If the head was tilted 10 degrees, then everything is off. Then we have to transfer the axis, so 155-degree axis, or was it 55 degrees? Well, it makes a difference. You just drop the 1. And then we have to find 180. We have to worry about cyclotorsion, and then my pen marks. I have the same problem. Sometimes I get a nice little precise mark, and sometimes it bleeds, and sometimes it fades. I am using, because I have the IOL Master, the Callisto system that was just referred to. And basically, you're avoiding this whole transfer of data. You're using the IOL Master. And what's nice about it is if you have the IOL Master 500, all you do is you buy a camera that you put over it, and every time you do an imaging, every time you do the calculation, you get an image and you capture it. And later on, you upload it to this Forum workstation, which is just a management software program, and that can communicate with the operating microscope through this machine called Callisto, which is basically a computer and the software, and whether you transfer it by a thumb drive or over the internet, you basically, as Dr. Titia showed, match up the limbal vessels, and now we can actually see the 180-degree axis. We can see the axis that the IOL Master thinks we should have for the toric lens, and I can change it. If the IOL Master says 45 and I want to make it 50, I just program the 50-degree axis. So everything is transferred over according to these limbal landmarks. And so I think this is going to improve the accuracy enormously because of everything I said before. If the patient's head was tilted, the patient's lying down, there's cyclorotation, it doesn't matter because the IOL Master is already determined based on those blood vessels which is the limbus. This is just showing that the system also can overlay a rhexis marker. And then this is basically, again, the toric IOL. And as was nicely shown, you have these sort of 3 parallel lines. And it's very interesting how using the system you can really be very precise about aligning it. And I think this is a real advance. The thing I want to talk about is intraoperative aberrometry. I have no financial interest in Alcon or in the Aura system. Where I think this has really become a must for me has been in the post-LASIK eye. But I certainly use it with toric IOLs for any time I do an astigmatic keratotomy, and certainly a multifocal IOL. There is a charge to using it. I don't use it, therefore, on every patient, and I don't charge every patient neither. So there's 2 sorts of readings you'll do. You do the aphakic. You've taken the cataract out, you pressurize the globe so you have a standard IOP, and it'll show you the recommended spherical power as well as the cylindrical power and axis. And then when you put the lens in, you can do another reading. Just think of it as an auto refractor. And can it confirm the spherical power? Did I choose the right power of the restore? Unfortunately not, because by the time you pressurize the globe, you push the lens back, the effective lens position is not where it's going to end up, and so it really won't help you there. But you can adjust the treatment of your cylinder, whether it be alignment of the toric or adding or extending your astigmatic keratotomy. I was a co-author in this paper, which was published a year ago. It's really the first paper of any kind in Aura. And what we did is we looked at post-LASIK eyes. And if you just look at the orange, this is on 240 post-LASIK eyes within a half or within 3/4 of a diopter. And so I tell patients, it still doesn't guarantee you get the right result, but it gets the best batting average over any of the other methods. And it really is independent of the clinical history method. So they don't have their records, you're not sure how reliable they are. This bypasses that. And that's probably the main reason that it drove us to do the aura system. But what about astigmatism? This is the third generation of aura, and we can now look at continuous intraoperative aberrometry readings. It's like an auto-refractor that is continually displaying things. And so I use it for axis alignment. These are the problems that we have. There's a discrepancy. How often is it that the topo and the Ks and the IOL master, they're all a little different. They don't agree. What about the head being a little tilted? What about if my ink marks, it should have been a little higher, but it's a little lower? And then, as we just talked about, the effect of the incision. What about if there's a discrepancy in the power? One says I need a diopter. The other says I need a diopter and a half of correction. What about posterior corneal astigmatism? So what it does is you do an aphakic reading, and that's my chance one more time to use this as a tiebreaker. Did I want a T4 or a T3? Did I want a 18 or an 18.5 diopter? It will basically make a suggestion, and I can use it as a tiebreaker. So here's a toric lens. You see the marks. And then I go over to the aura system, and I'm going to now do an aphakic reading. And this is unedited, so you can see in real time how much faster it is. I line it up, and it's basically saying the top there, 1 diopter at 90. So I press it, it does 40 readings, and it gives me this screen for my toric lens. I'm going to do a second reading just because it's so fast. The patient is fixating at this point. I've got another average of 40 readings, and I get a second reading. Okay? And here's what it's basically saying. It's saying a 22 diopter lens will get me a 0.32 result. And look at the astigmatism. They're both in agreement. They're both saying about a diopter at 95 or 100. Now, it has to make sense. And if I look at what I predicted and it's pretty close, then I'm going to use it. So now I have put that lens in, and let's go ahead and do the pseudophakic reading. Now, the first time I do it, I have not aligned it correctly. And if you look here at the top, you'll see the real-time reading. Okay, we do the 40 readings, and it says I have residual cylinder of 0.72 rotated clockwise. It says it wants me to rotate it. So here you can see my hook in there. I'm rotating the lens a little bit more. And if you look at the readings along the top, half a diopter, it's dropping. And I think I've got it okay, so we'll do another reading. Again, I got to make sure it's a firm eye. That's how you avoid artifact. And if it says NRR, that means no rotation required. That means I'm pretty much there. And that's what you're going to see, no rotation required. So that means just by moving the lens, doing the auto-refractor, I can see the difference. So if you look over here, that's the residual astigmatism at that moment we took the reading. And here you see the first reading was the aphakic reading. Then came the pseudophakic reading where I had a residual 0.72. That's because the lens wasn't really aligned where I wanted it. I rotated the lens and it dropped it down to 0.14. So that's the power of that. Now it's really helpful for astigmatic keratotomy because I can actually measure, which I previously couldn't, what the cylinder is right there on the operating table. So here's a case of a tetanus. This is the LRI pre, and then after I did the LRIs, I did another reading, and I can see that, lo and behold, there's a good reading. Now, it doesn't tell me exactly what it'll be. Maybe there's going to be regression, but at least I have some, a definite confirmation. And you can see on the right-hand side, this is aphakic. When I put the IOL in, I did another reading, a diopter at 97. Then I did my post-LRI, 0.1 at 171. Here's another one, restore. And I'm thinking, I didn't think there was that much cylinder. But then you put the restore and you do the reading, and there's a diopter at 175. Maybe there's posterior corneal astigmatism. Who knows? But this is the last thing I want, is a diopter against the rule when I wasn't expecting it. So I did an LRI, got it down to 0.2, using that right in the table. So let's just look at another case. 1 diopter, axis 154, okay? That's a pseudophakic reading. The lens is in place. So now I'm going to go ahead and, make my LRI. So this is a short, I designed, the one problem is the machine takes up some of your working space, so I actually designed a short LRI blade that Accutome sells, but really anyone can do this. So if you look at the very top, that's the real-time reading, and there is some artifact when you press in the globe, but I can actually see the readings there. Now I'm lifting up on the speculum because that can induce some artifact. And now I hit the capture button. My nurse does that. 40 consecutive readings, just like that. It averages it. And you can see the cylinder went from 0.85 to 0.23. That was all unedited, just showing you that. Okay? Let's do one more. Now this is a restore patient. And you see the residual cylinder is 0.96 at axis 175. So it's a multifocal patient. We've got some residual cylinder. So we're going to go ahead and do our LRIs. You can see that it's a diopter against the rule. So sometimes you're not expecting that, and you just evaluate the situation against the rule. That's where posterior corneal astigmatism may fool us. So I'm going to go ahead and I made one incision. You can see already the cylinder dropped down to 0.29 right up there at the top of the screen. So we're dropping. I lift the speculum up. So I only made that one incision. We're going to do a reading there. So you'll see up the top 40 readings, an average shows up, and now the cylinder went from 0.96 to 0.23. I can stop. This is an actual reading of the keratometry there. So that's the benefit of that. These are the shorter handles that I had talked about. In terms of the future, I think this is really where we are all going. You just heard all of this technology, all of the traps that there are that we can get in, and it seems kind of confusing. Well, Calhoun, you may have heard about this light adjustable lens. I won't go into all the issues and the technology, but it's based on a polymer that's diffusible, that you can basically reshape the lens and change the optical power of the lens using diffusion gradients. This is already published data from Europe on the spherical power. How would you like to have 100% of your patients seeing 20/25 uncorrected? Or taking your LASIK patients where there's 30% at 20/25, doing the Calhoun, treating the sphere, and getting them to 95%. But that's what we're doing now in phase 3. We're able to adjust astigmatism. So what happens, and we have almost all 600 eyes that will be done by the end of March. That completes the phase 3 in the United States, and so possibly even in 2 years we might have this. So instead of, you might tell the patient there's astigmatism, but you basically don't mark them. You don't have to worry about how much you're going to correct unless we're dealing with 4 or 3, but if it's within 2.5, you're going to do the surgery, put the lens in. You're not going to worry about posterior corneal astigmatism, surgically induced astigmatism, effective lens position. They're going to come back at a month. You're going to measure their refraction, and then you're going to treat it and basically make for them a customized lens. So I was asked to talk about the future. We know that this is the way to go for a LASIK eye. You're going to be able to adjust the refraction. It's like doing LASIK on the IOL. For anyone who wants to see well in the distance, they don't care about reading, we're about within half a diopter or better, 75%, the best. That means you have a 25% chance you're not going to be within a half diopter of emetropia. This will be an insurance policy. Toric IOL, like we said, we may not need to mark or worry about alignment. We're just going to measure the refraction post-op at 1 month and treat it. And then for presbyopia, I think this is really where mini monovision will become the dominant place. We don't have to worry about any loss of contrast, anything unforgiving. no unwanted images, because you're going to finally guarantee one eye is distant. You're going to be able to play with the other eye with a contact lens, demonstrate what it's like to be -1 versus -1.5 in the second eye. Maybe they don't like it, and you're going to be able to treat all of the astigmatism like that, and then do an extended depth of focus using spherical aberration like many of the companies are. Thank you very much.